Hello, hello. Welcome to tonight's Immunisation Coalition webinar event. Our topic this evening is HPV disease in Australia. My name's Susie Blackburn. I'm the events manager with the Immunisation Coalition, and I'll be moderating tonight's event. Firstly, I'd like to acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Tonight we have Angela Newbound presenting HPV, and she'll be speaking for about 40 minutes or so, which should leave us plenty of time to answer your questions. Angela's an immunisation education consultant based in South Australia and a member of the Immunisation Coalition. She's been involved in immunisation program delivery for over 20 years as an immunisation provider, program coordinator with roles with divisions of General Practice, South Australian Health and Medicare Local Network. Currently, she's working with the Primary Health Network, and I'd love to welcome you, Angela.
Thank you so much, Susie. And look, it's great to see so many people are on board and across so many different disciplines. So this is really great. Just to really talk about our big topic tonight being HPV or Human Papilloma Virus. So let's just have a look, a bit of a quick overview of it. So we know that about 90% of the general population are going to be infected with at least one genital type of HPV at some time in their life. And people with persistent HPV infection, of course, are at risk of developing a HPV-associated cancer. And most commonly for women, that it would be cervical cancer. And because this virus is just so common, it's actually often referred to as the common cold of sexual activity. The HPV tends to cause most papillomas. Papillomas, of course, are little benign growths that can form on certain types of tissue, and they can occur all over the body. They can occur in the form of skin warts, of course, but they do love the moist linings of the insides of the body, such as the gut and airway as well. And of course, they can also cause genital warts. So we do know also that there is this link between HPV and cervical and anogenital cancers, but researchers are sort of saying that it could take up to around about 10 or 30 years even for a HPV to develop into a malignant condition. Less than 50% of precancerous cervical lesions form a transition to being a cancer. So it's something that, just needs to be caught fairly early. So once again, we look at the types of cancers that HPV is known to cause. Genital warts, of course, are one of those, like I said, and that's mainly the serotypes of 6 and 11. There are HPVs, of course, that cause the majority of cervical cancers, like I just alluded to, and is also responsible for many oropharyngeal cancers, as well as those other anogenital cancers. And particularly HPV 16 and 18 seem to be the serotypes that cause the majority of these particular cancers. So we know there's around about 100 HPV genotypes that have been fully sequenced, and the genotypes are differentiated really by that sequence variation in those major genes. They differ in their preferred site of infection, and there's probably around about 40 HPV types that infect the anogenital tract. So out of all of those HPV types, types 16, 18, 31, 33, 35, 45, 52, and 58 are considered to be the high risk types because they are the ones that will potentially go on and cause cancer. But the most oncogenic HPV serotype is actually HPV 16. So cervical cancer, of course, does remain a major public health concern, but other cancers, anal cancers, penile cancers, vagina, vulval cancers are relatively uncommon, but are thought to be increasing in incidence. And this is possibly due to increasing HPV transmission secondary to changes in sexual behaviour that's been occurring, over the generations. But there are some low-risk HPV types as well, and these are mostly associated with the non-malignant lesions, such as your genital wart lesions. So if we actually look at the disease, HPV requires there to be a breach in the epithelial surface to enter that basal epithelial cell level. The infectious virions are only produced, though, in that terminally differentiated layer of the epithelium. And evidence does suggest that HPV progresses successfully because it just does not induce an immune response. So it tends to infect and then just lay low and just evades that immune system that we have. So we know that we have an immune system that has better detection in the lower layers of the epithelium, but in these cells, HPV produces low levels of detectable elements, and therefore our immune system just doesn't recognise it. HPV infection doesn't involve the bloodstream either, which means there's another mechanism for it to evade our immune system as well. Most HPV infections are cleared spontaneously, usually within around about 12 to 24 months. But however, like we know, in some cases that HPV does remain in a latent infection and obviously can persist for some time and present later on as a cancer. So quite often HPV infections actually have no symptoms at all. Obviously, if we look at the incubation period, for example, and that's the time becoming infected to the time of developing symptoms, if you're going to develop any, it's around about 2 to 3 months, with a range really for genital warts of anywhere between 1 and 20 months. The infectious period, however, that's the time during which an infected person can infect another person for HPV really is actually unknown. But for genital warts, probably for at least as long as there's a visible wart present. Often these HPV infections don't cause any noticeable symptoms or other health problems. And visible infections, when you actually can see what's happening if there is a wart, for example. And these warts, of course, if they're on the skin, on somebody's hand or their finger, generally they look raised, but they can be flat, they can be single, or they can be multiple, or they can even form clusters that look like little tiny cauliflowers. Subclinical infection is possible, but in those individuals, HPV is found inside the skin cells and it's still able to spread to other people. So currently there's no approved screening for HPV in males. It's only for females in regards to cervical screening. So if men have any questions at all, they should really be talking to their GP or their health professional to get some advice. And there's no cure for HPV either. Removing the visible warts doesn't necessarily reduce the transmission of the underlying HPV infection. But like I said, around about 80% of individuals with HPV will spontaneously clear that infection over a period of time. So some high-risk types of HPV, including types 16 and 18, can take longer to clear from the body. And in some people, infection with these particular HPV types can remain for a long time. In these cases, there's a higher risk of developing significant cell changes or dysplasia, which can progress to invasive cancer if it's not detected early enough and treated. It is actually quite rare for HPV infection to lead to cervical cancer though, but if it does, it can take up to around about 10 years to do so. Remember, since December 2017, the cervical screening test has replaced the Pap test for screening for cervical cancer. And of course, that Pap test used to look for cell changes in the cervix. The cervical screening test looks for HPV. So that's where the difference lay. And they're looking for that HPV that may potentially cause those cell changes in the cervix. So cervical screening are checks that are done every 5 years, and they are looking for that presence of HPV, and definitely highly recommended for that early diagnosis and treatment of this particular infection. So at the point where those abnormal cells in the cervix bind together and form tumours, cervical cancer symptoms may then become apparent. And those most common signs are really listed here. So they're looking at things like vaginal bleeding, discharge, particularly if it's thick or odorous or tinged with blood. You know, heavier menstrual periods that might last longer than they normally do, pain or bleeding during sexual intercourse, painful urination, just to, you know, really just to name a few. But because many cervical cancer symptoms are also associated with other less serious conditions, such as an infection, a lot of women may not seek early medical advice. And this is where, you know, these cancers can form without people really knowing, and then potentially they're looking at lengthy treatments. So looking at how HPV is spread, most commonly transferred from person to person during vaginal or anal sex. However, penetrative sex doesn't have to happen. It's not the only way that HPV is transmitted. It can also be transmitted in skin-to-skin contact, either during oral sex or other types of sexual activities. So a person with HPV can certainly pass that infection to someone else, even when they have no signs or symptoms. So it really is a bit of a silent spreader. So anyone that is sexually active can get a HPV, even if they've only had sex with one person, even if they've only had sex only once. But the risk of acquiring a HPV infection, of course, increases with the number of sexual partners an individual has. So most of the time, a baby that could be born to a woman with genital warts does not have HPV-related complications. In rare cases, the baby may be born and develop warts in their throat. And this is quite a serious condition, and it's called respiratory papillomatosis. So this is where a papilloma or a group of papillomas, they'll grow in the larynx. They can therefore obstruct the breathing process, and the infant may require some laser surgery to prevent the warts from blocking its airway. Unfortunately, those papillomas may return after the baby has had that laser treatment. They certainly can transform into malignant tumours as well. So, you know, certainly because of this, it really is necessary to continually treat those current respiratory papillomas for sure. Certainly one of the signs that a baby may have a respiratory papilloma includes hoarseness or a quiet or weak cry. Obviously, airway obstruction in severe instances will be observed. So we've got a few other polls today. So this is our first poll. So what is the chance of transmission of HPV if you have unprotected sexual intercourse with someone who has a current HPV infection? Well, the actual answer to the question, surprisingly for some of you, is going to be C. The current chance is 50 to 80% of acquiring a HPV infection following unprotected sexual intercourse. So, who's at risk? Once again, we said that anybody that is sexually active is at risk and will most likely get a HPV at some point in their lifetime, and especially if they're not vaccinated. In 2018, La Trobe University in Melbourne surveyed about just a little over 6,000 secondary school students in years 10 to 12 from across Australia, and found that about 47% of students have already had sex. So if you're a parent of a teenager that's on this webinar tonight, you might just want to wonder what your kids are up to. Maybe you don't want to wonder what your kids are up to. But anyway, so they did this survey. They defined sex, if you like, as vaginal and or anal intercourse, regardless of the gender of the partner. Year 10s were, thankfully, much less likely to have had sex yet. 34% have had sex, compared to the year 11s at 46% and year 12s at 56%. So the average age for sexual intercourse in Australia is around about 16 years of age, according to the survey. So there are a range of biological-based factors for HPV, and the high prevalence of HPV among HIV-infected women is thought to be due to the compromised immune system that's caused by the HIV infection. And this allows that viral persistence, if you like, of HPV increasing, and therefore they have a higher chance of this infection resulting in a cancer. The first sexual intercourse in some studies has not been related to HPV risk, but in other studies, it has been associated with HPV prevalence. Some studies are suggesting that the older you are, having your first sexual intercourse was a risk factor for high-risk HPV infections or multiple HPV infections. Age itself is an intrinsic host factor that merits a little bit of extra attention because it is one of the few biologically based factors that is associated with the risk of acquiring HPV infection. Age is also associated with that ability for that viral persistence as well. So the genetic polymorphism is where there's an alteration in DNA sequence, and usually this does not directly cause a disease, but rather it might serve as a predisposing factor. And a large number of studies have suggested the possible correlation between genetic polymorphisms of cancer susceptibility genes and the high risk of human malignant tumours. There's also behaviourally based risk factors also that we need to keep in mind. And these are usually shown according to data internationally, that there's a high prevalence in young women who've had their first partner and are monogamous. with HPV infection rates of 30% within the first year of becoming sexually active, and about 48% within 3 years of becoming sexually active. So several studies have really looked for HPV infection, particularly with new partners, and the partner's sexual history as well will play a really big role. Studies have also demonstrated cigarette smoking is associated with HPV viral load and therefore HPV prevalence in incidence as well as persistence. And this might be because of the ingredients of the cigarette smoke, which have been shown to really modify the function of immune cells. And one such ingredient is a toxin called aldehyde, which affects neutrophil function, causes DNA damage, and has been shown to suppress that resistance to pulmonary infections as well. So smoking should really be stopped. If anybody's a smoker out there, you really, you know, it's not a good thing to be doing. It does increase viral load by weakening the cellular immune response. So encourage your patients to give it up, and particularly if they are young individuals and engaging in a lot of sexual activity with a lot of different partners. So if we're looking at the crude rate here, so this is the 100,000 men or 100,000 women per year. So the HPV and related diseases summary report in 2022 stated around 41% of oropharyngeal cancers, which mainly comprises the tonsils and base of the tongue, are caused by HPV, and HPV 16, of course, being the most prevalent HPV type. So in regards to cervical cancer, this report that I was just citing also states that the current estimates indicate that globally, every year, over 550,000 women are diagnosed with cervical cancer, and around about 311,000 will die from the disease worldwide. Worldwide, cervical cancer ranks as the 4th most frequent cancer among women, the first 3 being colon and rectal cancer, then breast cancer and lung cancer. But it's the 2nd most common female cancer in women aged 15 to 44 years within the world. Australia has one of the lowest rates of cervical cancer mortality, but 328 deaths is way too many deaths. That's way too many women dying of this particular disease. According to Cancer Australia in 2021, it's estimated that a female had a 1 in 663% risk, or 1 in 663 risk of dying from cervical cancer by the age of 85. We know that cervical cancer is one of the most preventable and treatable forms of cancer, but continued participation in these national screening programs, as well as getting boys and girls vaccinated against HPV through the HPV immunisation program, is absolutely vital in eliminating cervical cancer as a public health problem. So there are many types of HPV. We established that a little bit earlier in the presentation, and of the 40 known mucosal HPV types, type 16 and 18, as you can see here, are the most common causes of HPV-associated cancers. A further 11 types are classified as carcinogenic, and there's another type, which is type 68, which is probably carcinogenic. About 8.5% of women in the general population are estimated to harbour cervical HPV 16 and 18 infection at any one given time. So clearly HPV 16 and 18 are the most common causes of cervical cancer. 16, however, is the most common type of cancer for head and neck cancers, and as I've previously mentioned, as well as other anogenital cancers. HPV 16 and 18 are the most common HPV types all around the world, and account for just so many of those cancers everywhere else in the world, as well as Australia. So who should be vaccinated? So anyone who's not vaccinated and is sexually active is at risk of acquiring a HPV. So anyone over 9 years of age who wants to protect themselves against HPV infection can certainly talk to their doctor or their parents about getting vaccinated. However, the vaccine's not funded until the first year of high school as part of the school immunisation program. And in most states and territories, that's year 7. South Australia is just transitioning, really. This is our very first year of high school starting in year 7. So this year our program is still being delivered in year 8, but that's expected obviously to change and be brought down in line with the other states and territories and be administered as part of the year 7 program. So the optimal age for this vaccine to be received is 12 to 13 years of age. So that's, like I said, that's the year 7 age group, and certainly prior to any sexual activity. If we can get this vaccine into these young adults or these young teenagers before they become sexually active, then it's going to provide them the highest level of protection that we possibly can. We definitely want to vaccinate these HPV naive individuals. If they have already had some sexual experiences, it's still beneficial for them to be vaccinated. The vaccine will protect against other strains that potentially they have not yet been infected with. So people aged up to their 20th birthday can receive 2 doses of the HPV vaccine free of charge as part of the NIP, or the National Immunisation Program, if they miss out on their school program vaccines. So these catch-up vaccines for older children really are supported, or older teenagers are supported through general practice generally, and certainly participating local councils or community health services, and certainly the local councils will certainly be following children up if they have missed those doses at school. According to the Commonwealth, if an individual is receiving their first dose of HPV vaccine once they have turned 15 years of age, then they should be receiving a 3-dose schedule. According to the Commonwealth Government, only the first 2 doses are funded under the NIP, but I would strongly recommend that if you see an individual in this particular circumstance, then please contact your local health department and seek some advice. Obviously, people with significant immune compromising conditions do require the 3 doses, and that is really because obviously their immune system is not working quite as robustly as somebody else that is immune competent. So who else should be vaccinated against HPV? Certainly, studies have demonstrated that HPV infection amongst men who have sex with men is a primary risk factor for anal cancer. It's a condition amongst these men that exceeds the prevalence of cervical cancer in women. So in contrast to cervical HPV infection in women, which decreases with age, the prevalence of HPV infection in men who have sex with men remains high, around about 57% across all age groups. Another group is women with high-grade squamous intraepithelial lesions or cervical intraepithelial neoplasia. These women are at higher risk of cervical cancer compared to the general population, even after they have had adequate treatment. So it's really important to keep your eye on these women that are attending your practices or organisations and talk to them about HPV vaccine. Obviously, we talked about those people with significant immunocompromising conditions, and we know chronic immunosuppression for various reasons is a really important risk factor for persistent infections, including HPV infections, which increases their risk, of course, of a HPV-associated cancer. And because that immune response is so much less likely than somebody who's immune competent, these individuals should really have a 3-dose schedule, and all 3 of those doses are funded under the NIP for those particular individuals. So we've just come to our second poll. So is routine vaccination recommended for all adults 19 years and older? You've got 4 choices. No, as they're less likely to have been exposed to 1 or more HPV types through sexual activity. Or yes, all adults should be routinely vaccinated with HPV vaccine. Or no, routine vaccination should be started at 17 years of age. Or yes, adults can be given an oral dose or an intramuscular dose of HPV. So congratulations to 52% of you that answered A. So the Australian Immunisation Handbook states that vaccination of adults aged 19 years or over 19 years against HPV is not routinely recommended. However, some adults may benefit from HPV vaccination. When deciding whether to vaccinate adults, consider their likelihood of previous exposure to HPV and their future risks of HPV exposure. So bearing in mind, this vaccine does work best when it is given to HPV naive individuals. But like the handbook says, there still may be benefit vaccinating somebody that is older and has already been sexually active. So we've got preventative vaccines, which is very exciting. And this is what you're out doing all the time, is vaccinating people as a prevention against disease. So in 2006, the TGA approved Gardasil. And only a year later, Australia became the first country that rolled out a national HPV vaccination program using the 4-valent HPV Gardasil vaccine. Now, back then, this program was really marketed heavily. There was a lot of marketing around this, but it was marketed as a cervical cancer vaccine. And therefore, only female adolescents were eligible to receive the vaccine. There was also a catch-up program at that stage for women up to 26 years of age, but that catch-up program ended on the 30th of June in 2009, so it was only a 2-year catch-up program. In 2013, the Australian government extended the vaccination program to include teenage boys. Now, I don't know about you. I have a son. I know he doesn't have a cervix. Well, I'm assuming that he doesn't, because most men don't. All men don't. And so therefore, this caused a lot of confusion in the school program, with parents going, well, why are we vaccinating the boys? And unfortunately, there hasn't been a big education program to help those parents understand the importance of their sons also getting vaccinated against HPV. It's going to not only protect their son from one of those anogenital cancers, but it will certainly help protect any partners that their sons have. So it's something definitely to be talking to parents about, and definitely talking to male adolescents about. So we actually have 3 types of HPV vaccines registered for use in Australia. Gardasil 4 is the 4-valent vaccine. It protects against 4 different serotypes, which is types 6, 11, 16 and 18. Once again, bearing in mind that 16 and 18 typically are the leaders of causing cervical cancer cases in women, but types 6 and 11 are responsible for almost about 95% of genital wart cases in both males and females. Cervarix is another vaccine that's registered for use in Australia. It's available on private prescription. It only protects against the 2 serotypes that cause the most of the cervical cancer cases. Does not confer any protection, obviously, for genital warts. And we also have Gardasil 9, it was the 9-valent HPV vaccine. So this is the next generation Gardasil vaccine. It's the one that's currently funded for the school immunisation program under the National Immunisation Program. So this is a 9-valent vaccine, protects against HPV type 6, 11, 16, 18, 31, 33, 54 and 58. So the school immunisation program offers all students a 2-dose schedule of Gardasil 9 in the first year of high school. And like I said before, the aim of the game really is to vaccinate them before they become sexually active. We definitely want to catch them up if they have missed that school vaccine dose. And certainly they can access that free vaccine, like I said, up until their 20th birthday. Also remember, there is never a need to restart an interrupted HPV vaccine course. So if you see an individual who had 1 dose of vaccine in the school program, but they didn't go back and get their 2nd dose, if you are seeing them today, and they qualify for a free vaccine, of course, you would be giving dose 2 to them today. You don't restart a course if there is evidence that they have already started a course. So any person who received the 1st dose of a vaccine under 14 years of age, but who has received no further doses, certainly can finish their course off with that final 2nd dose. Just making sure that those minimum intervals between the doses have been observed. And if it's the 2-dose schedule, that minimum interval is 6 months. Interrupted 3-dose courses, definitely just adhere to those minimum intervals between doses 2 and 3, which is 3 months. In fact, the wider the spacing between the doses, the better the immune response, to be really quite honest. So we're up to our 3rd poll of the evening. This is our last poll. So tell me, please, which statement is true? 9-valent HPV was not well tolerated in clinical trials when co-administered with DTP and meningococcal ACWY vaccine. Or 9-valent HPV vaccine can be used to complete a HPV vaccination schedule commenced with the 4-valent or even a 2-valent. Or the 9-valent, 4-valent or 2-valent vaccine is 0.5 ml administered subcutaneously, or those vaccines are 0.75 ml administered intramuscularly. All right, so congratulations to that 62%. The answer is actually B. So 9-valent HPV vaccine can be used to complete a HPV vaccination schedule commenced with either 4-valent or 2-valent vaccine. So definitely a course commenced with one vaccine can be completed with another, noting though that the protection against any HPV types not covered in each dose may be less complete. So obviously, if somebody has had a dose of 4-valent HPV and you're going to be vaccinating them with 9-valent now to complete their schedule, obviously those additional serotypes in the 9-valent are potentially going to have, obviously lower effectiveness. So a second course of HPV vaccination using the 9-valent Gardasil vaccine in those that have received the 4-valent quadrivalent vaccine or the bivalent or the 2-valent Cervarix HPV vaccine is certainly not usually recommended. So if they've already completed their course, There's no reason to give them a 9-valent vaccine now. Because realistically, the greatest benefit with these vaccines is against serotypes 16 and 18, because they are the ones that are causing the majority of these anogenital cancers. So who shouldn't be receiving HPV vaccine? So clinical trials and limited data from observational studies where HPV vaccine was inadvertently given to pregnant women have actually indicated that there's no increased risk of adverse events on the fetus. However, HPV vaccines are not recommended in pregnancy, and generally vaccines aren't recommended in pregnancy unless, of course, it's influenza vaccine, it's COVID vaccine, or it's pertussis vaccine. If a woman becomes pregnant during a course of HPV vaccination, it's recommended just to stop the course, wait until she has her little baby, and then just continue on with the course after the delivery. And as of course with any vaccine, if someone's had an anaphylactic reaction to a previous dose of vaccine, that is the absolute contraindication to any further doses. And particularly also if they've had an anaphylactic reaction to a component of the HPV vaccine that you're going to be giving them. So quickly looking at HPV prevention and other prevention methods. I mean, obviously cervical screening aims to detect and treat precancerous abnormalities that might otherwise progress to cervical cancer. And so cervical cancer screening more frequently will detect precancerous abnormalities than cervical cancer. But this is really reflected in the observation that most cervical cancers, more than 70%, occurred in women who have never been screened or were lapsed screeners, therefore obviously not having a screening test for some time. Cervical cancers detected through cervical screening have shown to lower the risk of causing death by 77% compared to cervical cancers diagnosed in women who had never been screened. So please encourage women to have HPV screening as well as HPV vaccine, particularly if in the HPV naive individuals. But like the handbook says, HPV vaccine can be given to people so that are sexually active, that might be a little bit older. So talk with them and assess their risk. So this particular study was looked at in Victoria. Women who were vaccinated against HPV when they were younger were shown to be much less likely to need treatment for pre-cancer or cancer during their lifetimes. The vaccine also protects both men and women from acquiring genital warts, of course, and this graph shows that the vaccine is protecting women from developing those precancerous growths during their late teens and early 20s. So it's been an exceptionally effective program. So if we look at the effectiveness of the vaccine, HPV vaccine provides almost 100% protection from 9 HPV types. If all of the doses were received at the correct intervals, if your vaccines have been stored correctly, and if it has been administered before the individual has had an infection with any of those HPV types. So almost 100% protection is fantastic, but there's a few caveats around that. So of 30 systematic reviews that included male and female participants aged 9 through to 76 years from multiple countries, all of the reviews evaluated post-vaccine seroconversion. HPV infection rates, precancerous or benign lesions and adverse events. None of the researchers reported, though, on oral or oropharyngeal lesions. And the results from the reviews really showed that compared with those who received a placebo or a non-HPV type vaccine, HPV vaccinated participants had statistically significant higher rates of seroconversion. Of course, the reviews have found evidence that the available HPV vaccines are safe, they're effective, they're efficacious around vaccine type HPV infection and HPV associated cellular changes, including those precancerous and benign lesions. So, wow, what a successful program. This has been hugely successful, this program. We've had another highly successful program in our young babies, which is rotavirus vaccine. But in our adolescents and our young adults, my goodness me, this has been a fantastic program. The Australian Institute for Health and Welfare reported HPV disease cases in adolescents and young adults decreased from 545,000 cases in 2005 down to 291,000 in 2015. And that's a 47% reduction, which is just absolutely huge. So can we do better? Yes, we absolutely can. And Julia Brotherton and her colleagues recently published in the Australian and New Zealand Journal of Public Health discussing HP vaccination completion estimates, and cross-sectional analysis found completed course coverage, which is 2 or 3 doses in the cases where it needed to be 3, for females at 15 years of age in 2020 was only 81.5%, and for males 78.6%. This we can do better. We just need to educate these parents and educate these young individuals about receiving this vaccine. If we can improve the uptake in the school program, we can further reduce disease incidence in these young people, which is so, so important. So many studies have demonstrated that HPV vaccination reduces the incidence of HPV infection and subsequent cervical cancer. The Australian Institute of Health and Welfare data in 2019 revealed that HPV vaccinated women had a 41% lower risk of high-grade abnormality than unvaccinated women. A Swedish study, on the other hand, of nearly 1.7 million women conducted over an 11-year period found that there was a 63% reduced risk of being diagnosed with cervical cancer among females who had been vaccinated compared with those who hadn't. So these studies have demonstrated HPV vaccinated women also were more likely to participate in cervical screening. So they are the acceptors of vaccines, they're acceptors of screening programs. And of course, those individuals are much less likely to have a high-grade lesion. So HPV vaccines, very, very well tolerated. And this has been looked at extensively, reporting adverse events across Australia were consistent with data from similar surveillance systems internationally. Like I said, not recommended in pregnancy, but there's certainly good research to say that it has not contributed to fetal loss or congenital abnormalities across the globe. So of course we have had some anxiety related events where there was sort of a mass fainting episode. So we do certainly bear in mind these students may well faint with the sight of a needle or the thought of a needle. So definitely make sure that people are sitting down, that they're seated properly in a chair. They're going to reduce the risk, if they were to faint, that they're going to fall to the floor and have an injury. But really, adverse events, very, very similar to other vaccines that these individuals would be receiving. So the AIR is a database, therefore, can only be as good as the data that it receives. As of July last year, in 2021, vaccination providers are required to report all NIP vaccines to the register. And while there's no mandate to report private script vaccines to the AIR, it is best practice. A complete vaccination history helps parents keep their children's vaccinations up to date. It allows providers to check vaccine histories just to make sure that they're not under-vaccinating or even over-vaccinating their patients. AIR does send out reminder letters to parents for their children if they are under 14 years of age and if they're overdue for vaccine. For privacy reasons, anyone that's 14 years and older can get their own immunisation history statement, and they can do that obviously by contacting the register or asking their vaccine provider to print one off for them. So treatment-related conditions, very, very quickly here, it's important to remember that treatment for genital warts does not get rid of the virus. It only treats those visible warts. They can be done by treated through cryotherapy, where the warts are frozen off with liquid nitrogen, but they might require several treatments. We've got imiquimab cream, which is applied once a day, 3 times a day for up to 3 months. And this treatment's actually not recommended for the use in pregnancy. Podophylotoxin, this lotion can be applied at home. Do need to be really careful about it spilling out onto the unaffected skin though, so it's a lot more effective on multiple warts that are obviously easily accessible, and certainly pregnant women shouldn't be using this particular treatment either. Obviously laser or diathermy treatments available, and this is usually used if there's a large number of warts or when all of these other treatment options haven't been effective. So, but remember, once again, this procedure does not get rid of the virus. It just helps get rid of those visible warts. So the treatment recommended for cervical cancer will certainly depend on the stage of the cancer, the person's age, what their general health is, and whether they would like to have children in the future. Definitely early or localized cancer is usually treated with surgery to remove the cancer. Women may have radiation therapy combined with chemotherapy after that surgery. Locally advanced cancers, which are stage 2 or 3 cancers, are usually treated with 2 types of radiation therapy, chemotherapy and radiation together, followed by internal radiation therapy. Surgery might or may not be used. Obviously, with advanced cancer or stage 4, they may have radiation therapy, they may have chemotherapy, targeted therapy, they may have combinations, they may have surgery. So just to conclude, we've just really got to remember that there is no perfect treatment for HPV infection, and not everyone requires treatment. The best thing that we can do is to recommend and encourage HPV vaccination, especially in HPV naive individuals, and continue to really strongly recommend cervical screening and send out those recalls to women who are due for screening. So thank you very, very much for listening. I hope that you have found the webinar really informative and are taking away at least one new piece of information tonight. And if you are, then yes, I think that I've done my job.
And you always do it so well. Thanks, Angela. Do you know what? We've been running these webinars, you and I, now for about 3 years. And I don't think we've ever had this situation before. We have no questions in the Q&A box.
Marvellous. Okay.
I have got a couple that I've written down, but I'm looking at the time thinking we're actually over the hour.
Yeah.
So what I might do is just wind up a little bit. And I think the reason why there's no questions, of course, is because you've done such a great job. And because obviously HPV is just one of those diseases that Australia is dealing with very well, and the immunisation, in fact, is so effective that yes, we're doing very well. So thank you very much to you. If you would like to put a question in the Q&A box, we'll be in for a couple of minutes, so I'll keep an eye on that. And in the meantime, I want to tell you that on June 22nd, we have Professor Robert Boy speaking on COVID in Australia. Now, Angela, I think that's going to be an interesting one because, you know, it's so prevalent still now. So I think that Professor Boy will be able to really give us some new information and current. So that's on June 22nd, and we'd love for people to join us then if they can.
And I think, you know, absolutely join that webinar if you possibly can. You know, we've seen our flu numbers absolutely skyrocketing. Absolutely. We are probably going to be one of the first countries in the world, Susie, where we have got high rates of influenza circulating and high rates of COVID circulating at the same time. We really are going to be a bit of a test case across the world to see what happens. Is there going to be flurona, you know, the co-infection between flu and COVID? Yeah. We really are in a bit of trouble this year. So please get people vaccinated against flu. Please, please, please.
Yeah. And our influenza webinar that we ran in, I think it was late March, is actually recorded and available on our website if anyone missed that and would like to go back and review that. So thank you so much, Angela. Thank you everybody for attending. We look forward to having you back at our next event. We've got COVID in June and pneumococcal disease with Angela in July as well. There will be a short survey after the event. We'd really appreciate your feedback. We'd love to hear what else you'd like us to consider with regard to our educational events. So on behalf of the Immunisation Coalition, I wish you safety, wellness, health, and a very good evening. Thank you.
Absolutely. Stay safe, everybody. Thanks, Susie, and thanks for joining everybody.
Okay.
Good night.